Good evening, and thank you for joining us. I'm Craig Davis, Director of Adult Services, and on behalf of everyone at the Chicago Public Library, welcome. Tonight's virtual program is another in our ongoing series of literary, cultural, and civic programming.
Good evening,
and also in
and thank you for joining us. I'm Craig Davis, Director of Adult Services, and on behalf of everyone at the Chicago Public Library, welcome. Tonight's virtual program is another in our ongoing series of literary, cultural, and civic programming. Good evening. I'm Craig Davis, Director of Adult Services, and on behalf of everyone at the Chicago Public Library, welcome. Tonight's virtual program is another in our...
Oh, wait a minute. Are we okay now? Good evening, and thank you for joining us. I'm Craig Davis, Director of Adult Services, and on behalf of everyone at the Chicago Public Library, welcome. Tonight's virtual program is another in our ongoing series of literary, cultural, and civic programming, and also in support of our Disability Awareness Month, celebrating 31 years of the passage of the American with Disabilities Act. During tonight's program, we'll be monitoring an online chat for questions from the audience for a brief Q&A following the conversation. So please feel free to ask questions in the chat. Tonight, it is my great pleasure to welcome author and psychotherapist Jonathan Foiles. Mr. Foiles is a lecturer at the University of Chicago Crown Family School of Social Work, Policy, and Practice, and a psychotherapist in private practice in Chicago. He is the author of This City is Killing Me, Community Trauma and Toxic Stress in Urban America. The program tonight will introduce Jonathan Foiles' latest work from Belt Publishing, scheduled for a September release and titled Misdiagnosed: How Bias Distorts Our Perception of Mental Health. So now, please join me in welcoming Jonathan Foiles.
Thank you, Craig, and thank you to everyone at the Chicago Public Library. It's really my pleasure to be here this evening. My library card has gotten a lot of use over the years. It's one of the first things and best things I did when I moved to Chicago, so it's really exciting to be here tonight. As Craig said, I'm going to be talking about my new book this evening called Misdiagnosed: How Bias Distorts Our Perception of Mental Health. So I thought I'd talk in the beginning, I'd be kind of giving you a lay of the land about the genesis of the book, then do a little bit of a reading from it. I've long been interested in the history of mental illness, or mental health. What counts as mental health or mental illness, where it's thought to come from, what's thought to make it better, make it worse. And if you study that much at all, you'd notice a curious thing, for instance, for many centuries, hysteria was thought to be this sort of pernicious malady that afflicted primarily women, sometimes men too. And there were various thoughts and reasons about what brought it about and different thoughts about how to fix it. And probably most famously, the early Freud was very interested in the treatment of it. And psychoanalysis actually developed around the treatment of hysteria. And so that was a big concern for centuries. And then, Freud in 1895 publishes his studies in hysteria, and then just a few decades later, it virtually disappears. And that always intrigued me, and I was curious about, where it went, and to be clear, I don't believe in the diagnosis of hysteria. I don't find it helpful, or, I don't think it's something that exists, but it was curious to me that something could be such a concern for so many people for so long, but then all of a sudden, because of shifting cultural tides and different mores and understandings of the mind, it could virtually disappear. But of course, those patients that used to be diagnosed with hysteria didn't disappear, and as I began to think about it, I began to see vestiges of the logic of hysteria and diagnoses that we still use today that aren't seen as discredited or seen as scientific and objective. And so that got me curious, and I continue to pursue that path, and I'll give another example in the reading tonight. But in the 1619 project, there is some mention of a mental illness that was thought to impact enslaved people called Trappedomania. And that is not something that exists in the slightest these days, but I was curious if the same racial logic, popped up, had vestiges in other diagnoses. And so I began to just reflect on this, and over time, isolated some historical diagnoses that have been consigned to the dustbin and some contemporary diagnoses that we still use, and began to see how the same logic still connects both, and to do a bit of an excavation project in that. And I'm also just interested in the idea of diagnosis as a whole. I think a diagnosis can mean a lot, and a lot of different things. Where I work now in private practice, it's not all that important. I mean, I give them, I talk about them with my patients if that would be helpful for them. But it's mostly exists as something that I put on their billing when I have to submit it, which is a whole nother issue that I don't have the time to get into, but is worth looking at. But when I worked in community and mental health, they had far more weight to them. When I met with a new patient, instead of what I do now, which is just having a conversation about what's going on and how I might be able to help them, I had to send them through a several hundred questionnaire about their life, their experiences that included like a recitation of any traumatic event they've ever had, and a list of their mental health symptoms, what I found to be invasive questions about their physical health, including their their sexual practices and that sort of thing. And so within that, a diagnosis had much more of a weight. You had this intake process and ended with the diagnosis, and then that sort of set up the treatment. And within that, a diagnosis could be really determinative in terms of the level of care they received, or the amount of care they were able to receive. And that can be the case in private insurances too. I know certainly that happens, but it tend to be more of an issue in public aid ones. And I think I've seen patients who feel strangled by their diagnosis and others who feel liberated by it, oftentimes the same word or set of words. So I wanted to just examine the idea of diagnosis in general, and then how it in the past and in the present reflects a lot of our own cultural biases and assumptions. So that's sort of where the book came, and now I'd like to do just a little bit of a reading from it. So I'm going to start with a chunk from the introduction, and then I'm going to move into a few selections from one of the chapters. So this is from the introduction. This is actually how the book opens. A young woman sits across from me, a shock of bleached blonde hair obscuring her face. Her gaze is focused on the tissue she is twisting in her hands. Bits flake off like snow and fall on the floor in front of my desk. She is here for an intake interview, beginning the process of unraveling her life story to get the help she has realized she needs. Her mother is already one of our patients. She is down the hall speaking with her psychiatrist. Madeline has told me that she is concerned about her depression, and she relates a number of symptoms that meet criteria for the diagnosis: persistent depressed mood, poor sleep, poor appetite, loss of interest in activities that used to interest her, lack of energy. She tells me that she has thought about killing herself. She also mentions that her entire family has discussed mass suicide, a disclosure that chills me as I try to calmly assess the seriousness of the threat. Her father overdosed on heroin just last week and was brought back with naloxone. It's happened so often that she's lost count. Hopelessness is the water in which her family swims. Before I proceed on to the myriad of other questions her public aid insurance forces me to ask her prior to beginning treatment, I check through a mental list of other symptoms to make sure I'm on the right track. Do you ever have times when you feel the opposite of depressed, like you could do anything and don't even need to sleep? Her tear-brightened eyes jump up to meet mine. Well, actually, yeah, sometimes I'll stay up all night and clean the house even though it doesn't need it. I might sleep an hour or two, or I might go a few days without sleep, but I actually feel pretty great. Do you have any issues with anger or irritability? Shame descending, she replies, well, yeah, I do tend to yell quite a bit. I cuss out my family. I mean, I've never hit them or anything, but I might throw things, punch the wall, stuff like that. During those times, do you do things you wouldn't really think of doing otherwise, or things that are considered to be pretty risky? She stares at me uncomfortably. Well, this is confidential, right? I assure her that it is. Well, anyway, I have tried cocaine when I feel like that, just to make the feeling last, but I haven't really told anyone that before. With a few more questions, I am reasonably confident that bipolar disorder better fits her experience. Setting aside the keyboard I had been using to type up my clinical impressions, I leaned forward to give her the news. Based on what we've talked about so far, I think that you have bipolar disorder. It is serious, but it is also very treatable. I'm really glad that you came in and decided to ask for help. Do you have any questions I can answer right now? For the first time, a smile cracked across her small face. I just thought I was crazy this whole time. I honestly just feel relieved to know there's a name for all of that, you know? Later in that same office, I sit across from one of my therapy clients, a young man named Michael. Someone else has already done his intake, and he arrives with the diagnosis, schizophrenia. Not that I needed to be told. While the word schizophrenia most often conjures up images of a person seeing or hearing things that aren't there, or conjuring fantastic narratives that aren't true, known as positive symptoms, the disorder also includes what we call negative symptoms, things that take away from a person's normal functioning. There's an interior hollowness, a depletion of one's energy, an inability to feel much of anything. Most people with schizophrenia will say these symptoms are the hardest part, and the medications that we have right now do little to help address them. Michael reports experiencing much of this, and like many millennials, he has turned to the internet to help him understand his symptoms. This has led him into the wastelands of YouTube and its algorithm, and he tells me what he saw. I've been watching videos of other people who are diagnosed with schizophrenia, older people. They were saying that life has been hell for them, and it just gets worse and worse. A lot of them said that they want to die. He is both right and not right, as I tried to explain to him. If schizophrenia is detected early, as his was, the outcomes are much better than if it is allowed to progress untreated. Since it is usually a disease that strikes in young adulthood, precisely when most of us feel that we're invincible anyway, and have no need to see a doctor, this is often easier said than done. However, the severity of the episodes Michael has experienced today is concerning, and a psychiatrist has yet to find an antipsychotic that hits the middle ground of blunting his symptoms without erasing his core identity. I try to explain all of this as gently as I can, but I can feel the tightrope underneath my feet. So what you're saying is that you really can't be sure, but they could be right? I don't want to end up like that. I can't. I end up doing something that I wouldn't do now, and that is to try to match his stories of endless suffering with those of other people with schizophrenia who have managed to thrive. From the perspective of the present, I realized that instead of allowing both of us to sit with his feelings, I grew uncomfortable, scared even, and acted out of my fears. But at the time, I did what I thought would help. Together, we watched a TED Talk by Ellen Sachs, an accomplished USC law professor who has also been diagnosed with schizophrenia. I can tell he is unimpressed, but he is kind and humors me. At the conclusion of our session, I check and he assures me that he has no plans to try to kill himself. Michael won't tell me for some time, but he will continue to watch those YouTube videos. He just grows more distressed as he imagines what his future holds, sees all the ways it might be constricted. When one of the videos mentions a way to kill yourself that's supposed to be relatively quick and pain-free, he will think about it. Months after our conversation, after several other sessions, he will try it when his family and I least expect it. But his story doesn't end there. He will be hospitalized then and a few other times, and somewhere along the way he will find the right combination of medications. They will help restore him to himself, and he will begin to allow himself to dream. He'll start to relate to the idea of schizophrenia in a different way. So the introduction goes on from there, but I just wanted to give you a sense from my own practice of the differing ways in which I've seen a diagnosis, even a similar diagnosis of similar mental illness, whether it's bipolar disorder or schizophrenia, either be like a beacon of hope for people or feel like a death sentence. And I think both are determined by a lot of factors outside of just the mental health profession. But that's from the introduction. I do want to go on now and read a few selections from one of the chapters. I'm going to actually be reading from the first chapter. This is chapter 1, Pathologizing Protest. When I worked in community health, I wore a variety of hats for my patients. I talked to them about their mental illness, of course, but I also helped them look for jobs and housing, discussed how they could share their experiences with other medical professionals, explained the slow process to attain disability benefits, and worked on many other things that I was not taught in school but picked up piecemeal along the way. Social workers take pride in being flexible and doing what it takes to help those in need. Thus, I wasn't surprised to be explaining to a longtime patient of mine named Al that he shouldn't, quote, act crazy, his words, at his upcoming disability hearing. Al had been assigned the diagnosis of schizoaffective disorder by his psychiatrist long before I started seeing him. Schizoaffective disorder, a branch of the schizophrenia tree, means that a person experiences the symptoms one usually associate with schizophrenia, hallucinations and delusions, but also experiences the symptoms of depression and or mania in the absence of such psychotic symptoms. It's somewhat of a bridge diagnosis between major depression or bipolar disorder and the psychotic disorders. Al was hoping that this diagnosis, along with some physical maladies, would suffice to convince the judge to award him disability benefits. A few decades prior, he had been a hairdresser, but racism had forced him to the suburbs to find work. When the shop where he worked closed, he found that his other options had dried up too. Occasionally, I would mention the variety of part-time jobs that existed in the neighborhood, but Al had grown up there and would often remind me that his long-deceased father had earned $15 an hour working in the factories that used to be in the neighborhood, before they fled to the suburbs along with the white people. He did not want to earn less than that years later. It was hard to argue with such logic. Al did not have to act crazy to get approved for disability. He let his voluminous records do the talking. Our sessions consisted of reminiscing about his childhood, processing the racism both overt and covert that he had experienced throughout his lifetime, and discussing the news of the day. I believe that he did truly suffer mentally. He had very little contact with people other than me, didn't trust people, and seemed to hear and see things that weren't there. I used to see a lot of patients like Al. There's also Marvin, who believed he had inherited inability to see and talk to spirits. Teddy, who claimed to be tormented by the sound of babies crying. Eric, whose outbursts of intense anger caused him shame and guilt in the aftermath. All had mental health symptoms that plagued them and shaped their interactions with others. All were also Black men. The strands of their stories were so infused with suffering that it was difficult to separate their symptoms from their history. Was Al depressed because he often self-isolated, or did he self-isolate because the only people he knew around him had chronic substance abuse issues? Was Marvin paranoid because the neurotransmitters in his brain were out of balance, or because he had been beaten by police upon multiple occasions in the past? How much of Eric's anger was due to the fact that he had very few friends left because so many of them had been murdered? All had ended up with diagnoses of severe mental illness along the schizophrenia spectrum, but there is clearly more at work in each case. Black Americans, and Black males in particular, are far more likely to be diagnosed with schizophrenia as compared with patients of other races, despite the fact that all ethnicities experience the disorder at the same rate. This doesn't just stop at diagnosis, though. Black people are also less likely to receive mental health services in the first place, and the care that they receive is often poorer. One study of the community mental health center's prescribing patterns found that whites were 6 times more likely to receive a second-generation antipsychotic medication, the contemporary treatment of choice for schizophrenia, while Black people were prescribed older drugs with riskier side effects. Black people are often subject to more coercive treatments, such as shots received on a regular basis instead of an oral medication. These depot medications, as they are known, can be great for people who struggle to remember to take their medicine, but they can also take away the element of choice from clients and become a tool of social coercion. Contrary to what you may think, this is, by and large, a Western problem. It is well documented but underreported that outcomes are actually better for people with schizophrenia in less developed countries. Beginning in the 1960s, researchers from across the world began meeting together to determine whether or not schizophrenia was a cultural construct or a malady present across cultures. They ended up deciding in favor of the latter, but upon their trips to the various member countries of what was known as the International Pilot Study of Schizophrenia, they noticed a recurring phenomenon. 2 American psychiatrists visiting Nigeria, John Strauss and Will Carpenter, were initially alarmed to see a woman whom we would diagnose with schizophrenia chained to a post in the yard of a local traditional healer. Once they recovered from their shock, however, they realized something important. Despite the admittedly poor conditions in which she was kept, the woman did not experience social isolation from her fellow villagers. She engaged in regular conversations with passersby who were happy to stop and chat with her. To be clear, we should not chain up those with mental illness, yet when we do it in the West, we don't put the people with schizophrenia in the middle of the community. Instead, we lock them away from everybody else. And then I go on to talk for a little bit about the beginnings of the diagnosis of schizophrenia, in particular, how in sort of the first half of the 20th century, the prototypical patient with schizophrenia was not what we would think of now, but was instead someone that was seen as kind of dreamy, artistic, head in the clouds type. And that's not to say that they often were treated brutally, because they were, but the diagnosis was gendered more as impacting women than men, and was seen as more infantilizing than what we think of these days. In this next section, I talk about what began to change. America began to change in the 1960s as the civil rights movement spread across the country, and the concept of schizophrenia evolved alongside these societal shifts. As the nonviolent rhetoric of leaders like Martin Luther King Jr. gave way to the perceived militant approach of groups like the Black Panthers, mental health became another means of policing racial boundaries. For example, the second edition of the Diagnostic and Statistical Manual of Mental Disorders, or the DSM, which was released in 1968, obviously a transitional year in this country, expanded the definition of schizophrenia. And for the first time, hostile and aggressive behavior were included as symptoms of the paranoid subtype. That same year, doctors Walter Bromberg and Frank Simon published an article in the Archives of General Psychiatry titled "The Protest Psychosis, a Special Type of Reactive Psychosis." In the article, Bromberg and Simon describe a new form of psychosis, ostensibly based on what they were seeing in their incarcerated patients, which was, quote, influenced by social pressures such as the civil rights movement, dips into religious doctrine such as the Black Muslim group, and is guided in content by African subcultural ideologies, and is colored by a denial of Caucasian values and hostility thereto. This protest psychosis among prisoners is virtually a repudiation of white civilization, end quote. Symptoms included the usual hallucinations and delusions, but also encompassed antisocial behavior, interest in Pan-Africanism or Islam, and attempts to develop an anti-white language. Bromberg and Simon theorized that the disorder arose when Black men became overwhelmed by their largely unconscious feelings of hatred towards whites and retreated toward an African ideology in order to assuage their guilt over the crimes they committed against the white race. The racism is clearly obvious, yet Bromberg and Simon were not outliers. Prominent ads for antipsychotics displayed crazed-looking Black mental patients, while other academic articles warned that Black men could develop psychotic symptoms as a result of participating in sit-ins or become delusional due to believing their civil rights had been violated. Perceived Black militancy became not just dangerous to the white world, but a sign of insidious illness. Black people literally disappeared into their hatred and fear of whites and became mentally ill. Such a move both allowed whites to disregard anything that Black Americans might say, since it was evidence of their shattered thinking, and institutionalized those who did speak up or revolt. Label someone's thoughts as delusional, and you ensure that neither you nor anyone else have to take them seriously. While the racism is less overt, it's hard not to think of Al and others like him here as well. Labeling them along the schizophrenia spectrum allows us, however implicitly, to sweep up all their other experiences under the mantle of their illness. I'm going to read one more selection from this chapter. I mean, this is where I connect the schizophrenia spectrum as it's often utilized in the present to disorders of the past. In thinking through the ways that schizophrenia has been used to silence the resistance of Black people against an often irrational society, I am reminded of another diagnosis once used to explain the supposedly inexplicable actions of Black Americans. Samuel Cartwright was a physician in the American South during the 19th century who sought to answer a question that perplexed him and many of his peers. What caused enslaved people to seek to run away? Cartwright believed that behind this phenomenon lay a heretofore undiscovered mental illness that he labeled Trappedomania in 1851, a portmanteau combining the Greek words for runaway slave and mad or crazy. While this mental illness had been theorized in the Southern judicial system since at least the 1820s, Cartwright was at first to propose both a diagnosis and a cure. Enslaved persons did not seek to run away because of the brutality of the slavery economy, but because they were mentally ill. Just as a century later, Black people protested Jim Crow not to fight for their rights, but because they were psychotic. Trappedomania was not only a Southern construct. It remained an object of general fascination across America that enslaved people could seek to throw off their shackles and run for freedom, a point usually made with reference to the supposedly pleasant conditions in which enslaved people were held. According to Cartwright, this was precisely the problem. Trappedomania arose because conditions were allowed to get too comfortable across the plantations of the South. As he wrote, On Mason and Dixon's line, two classes of persons were apt to lose their, I'm going to say enslaved persons, that's not what he says, but those who made themselves too familiar with them, treating them as equals and making little or no distinction in regard to color. And on the other hand, those who treated them cruelly, denied them the common necessaries of life, neglected to protect them against the abuses of others, or frightened them by a blustering manner of approach when about to punish them for misdemeanors. Before the enslaved people run away, unless they are frightened or panic struck, they become sulky and dissatisfied. The cause of this sulkiness and dissatisfaction should be inquired into and removed. Are they apt to run away or fall into this sort of consumption? That's the end of the quote. Cartwright proposed a golden mean for enslavers, not becoming too nice and thus failing to remind enslaved people of their status, while also not brutalizing them to the point where they would consider revolt. Is it fair to compare schizophrenia with the racist construct long ago consigned to history's wastebasket? While there is no question that schizophrenia names some people's experiences in a way Trappedomania never could, there are some similarities that should give us pause. As noted earlier, most of the factors correlated with schizophrenia result from structural inequality and oppression, which are the modified forms of that which kept Black people enslaved for centuries. It is also a documented fact that members of minority communities, particularly Black people, are far more likely to be diagnosed with schizophrenia as well as to be treated with drastic, often brutal methods. It is possible for an illness to also be a means of social control, which is what we see with AIDS, I would argue, and that is often the case with schizophrenia. To say that one's thoughts and beliefs fly in the face of logic is a profound claim to make. I have met people in the grips of delusional systems that defy common sense, yet these beliefs often paper over profound hurt and loss. And it's entirely possible to get it wrong. The clinic where I used to work had a day program for people with serious mental illness, offering group therapy and other outlets for social connection to people who are often profoundly isolated. One young woman who attended that group regularly displayed her suffering vividly, scratching at the air and yelling profanities at attackers only she could see. It was not apparent to anyone that she had graduated from a notable art school and received glowing write-ups of her paintings before she started hearing voices. Saying that someone is seeing things that aren't there or believes things that aren't true is an invitation to dive deeper in order to help them, not an excuse to write them off and bury them underneath powerful medications. We know that people with schizophrenia have the best outcomes when they're able to maintain their lives in their community, receiving the help and support they need while not being removed from where they come from. Mass institutionalization and mass incarceration shatter these bonds, stealing Black lives from their communities and subjecting them to the ever-increasing carceral state. Unfortunately, far too many neighborhoods and cities lack the sort of infrastructure to enable anyone, with or without mental illness, to lead a thriving existence. Alan never left his neighborhood, but it had long ago left him. In my practice, I've met many others like Al who need help that their communities can't or won't provide. That's bringing me to the end of my reading for tonight, so we're going to transition to the questions section.
Great. Thank you, Jonathan, for that. That was very interesting. We have a few questions here that I'd like to pose to you. First one. So there has been significant protest and civil unrest happening in the past year and a half in this country. I was wondering if you have seen any recent studies in psychology circles that are following the argument that the action of protest is associated with some type of mental distress.
Yeah, I've seen a little bit. I mean, I definitely think that it exists to be studied more. You know, I also think the stuff that I've seen tends to be more on not so much the wide-scale protests like we saw last summer, as important as those are, but the more like, for instance, like the Mike Brown protests in Ferguson or the protests in Hong Kong for pro-democracy protests. But what we've generally seen in those, and also just in studies that kind of studied things generally, is that the protests certainly were just like kind of the acts of oppression that precede the protests, you know, can cause traumatic symptoms. You know, in Ferguson in particular, there's a study that came out that I looked at that compared the reactions of like white people and Black people, both in mental health and just their overall disposition to the uprisings that occurred there. And it found that white people were more disturbed by the sort of interruptions to daily life, which I think is kind of an unfortunate indictment of the way that a lot of people who look like me approach those sort of issues in general, and that it did cause more negative mental health outcomes for Black people. But that, to me, in this book, "And the City's Killing Me," I write too about how, it's all kind of a piece in that people who live in defunded neighborhoods, neighborhoods that are subject to violence, both interpersonal and police, tend to are at higher risk for trauma-related symptoms anyway. So that doesn't surprise me. And I do think too that one of the most powerful ways of not getting over trauma, but of sort of integrating it into one's life story, is to try to make sense of it and use it as like a inspiration for change. So I think alongside of the trauma that comes from seeing another Black person gunned down by the police, the uprisings can also be a tremendous source of hope, both for people in communities and for those who participate in them. So I think it's kind of two-pronged in that regard.
Thank you. Secondly, you discuss in the book how the prison system reinforces and even causes mental illness in people. Can you talk about any new practices being put into place to help combat these issues, perhaps here in the U.S., but also is there anything happening overseas that might be of interest? And how can people help combat recidivism to help returning citizens who are reentering society from incarceration?
Yeah, I think those are important questions. I think at the root of it, I do believe in abolition. I do think that just the structure of prisons itself, it exacerbates and often causes mental health issues. There are people who have written on that far more than I have and know more than I do, who I refer people to, like Miriam Kaba, Ruth Wilson Gilmore, and Angela Davis. But that's just to say that kind of starting from that position, I think that changes made to the sort of the current carceral system are in some ways just Band-Aids on a much larger wound. But there are some things that have changed. In New York State and other states, there's movement towards this to end solitary confinement. Solitary confinement, being isolated by yourself for 23 and a half hours out of a day is brutal. And in New York State, in particular, recently, they limited it to 15 days at a time, which seems generous, and I guess compared to unlimited amounts of time it is, but that actually just puts it in line to not fall under the UN's definition of torture according to the Mandela rules. So it is progress, but it is progress from starting like really, really far back. And also those same rules say that solitary confinement should not be used for people with mental or physical disabilities, which we know is a large percentage of the prison population. And the ways that it fractures someone's conscience, I've seen. I saw a patient who spent most of his time incarcerated in solitary confinement, and being in the outside world, while exciting for him, was almost more than he could take. He would hear sirens go by and literally like cower in his bathroom. He's one of the sweetest people I've ever met, but he ended up like ending treatment because he just couldn't even make the trip to my office, So I think that ending practices such like that, or, the death penalty for juveniles, for instance, is another thing that comes up. I think those are good, but it's still a long way from where we should come, and I think conditions, not everywhere, but, overseas are better in a lot of ways. It would be difficult to enumerate just because we incarcerate so many people in this country as a percentage of the population, particularly, Black and Latinx folks, that, just incarcerating less people is also a mental health intervention, doing things that, help people is a mental health intervention. So in terms of reducing recidivism, I think the best thing to do that is just community investment. more people work, and also more people working in like community mental health centers and that sort of thing. I've seen some programs exist to help that. I think some where it kind of puts people in like what we would call affinity groups, like people who have similar experiences can be helpful, just because being a returning citizen can be profoundly isolating. That helps you develop connections. But I've also seen interventions that are purport to be like mental health interventions, but kind of focuses on sort of elements of like the criminality or the criminal conscience, which I think just takes what to me is a societal issue of mass incarceration and reduces it to a sort of a personal feeling of certain people, again, by and large, Black and Latinx people.
Thank you. You open the book with a discussion on the methods of diagnosis between physical and mental ailments and the expectations that are associated with each. How do you think the media has contributed to misinforming the public when it comes to diagnosis?
I think it's often hard in the media to have a lot of nuance. I will say that just in terms of not letting them off the hook, but just realizing that this is difficult. I do think that we don't do a good enough job of talking about how a mental health diagnosis is structured fundamentally differently than like a physical health diagnosis. Like for instance, a few years ago, I had an issue with one of my lungs, and they diagnosed that because they looked inside my lung and saw like, oh, there's this little part that's not working correctly, or not as it should be. And I can't read the scan they took, but if I wanted to, they can show me and I can see like, oh, that looks kind of weird. We don't have anything nearly similar with mental health. As I kind of mentioned in the introduction, if I see a new patient, I'm going to ask them lots of questions, and I'm going to observe. If someone's telling me they feel happy all the time, but they seem near tears, I'm going to think like, okay, maybe something's not adding up here. But by and large, it's patient self-report, which I don't think is a bad thing. It just means that that there is like there could be tests for depression, but it's not like seeing how much serotonin someone has or doesn't have. It's them saying like, do you feel sad this amount of time for this many days, that sort of thing. It is just fundamentally different. But I think what can happen too, so that's kind of one piece of it. But I think too, and this has maybe gotten a little bit better, but I still find examples of this way too much, is that mental illness is assumed to be like have like a causative role in like far too many things. Because I think it's hard for our brains to grasp nuance a lot, and particularly when it's something we don't understand, tend towards what seems like the simplest explanation. Like I'm thinking about the pilot a few years back in Europe, I believe, who was depressed and crashed the airplane that he was flying and killed everyone on board, including himself. I think a lot of people are quick to kind of latch onto his depression as a explanation for why someone would do that, because that does seem like something that's kind of hard to fathom why someone would do. It is to me too. But I don't, but it goes without saying, but I see several people with depression. I myself have had depression and have not had the urge to crash an airplane full of people. That's not suicide, that's homicide, at a mass scale. And so, depression may have factored into it, but it's not like depression yields this, and I was thinking recently, and I will say I have two toddlers. I barely see the movies anymore. I haven't seen this one, but the Anthony Bourdain documentary that came out recently, and a lot of the reviews that I read kind of ends with not maybe saying outright, but like postulating that Bourdain's relationship with like Asia Argento was a factor of the factor in his suicide. And the fact is we can't know. That's all guesswork, but we really like to try to like isolate a cause, particularly when something like the suicide of someone who seemed so affable and gregarious as Bourdain, to try to make sense of something that feels senseless. And that's a very human impulse, but that can lead us to take a lot of shortcuts that are really unfortunate, and particularly when it comes for people with mental illness, and particularly serious mental illness, is not fair to them in the slightest, and doesn't capture their lived experience.
Similarly to that, in recent years, we've seen a great rise in advertising on TV and social media about a wide variety of drugs that claim to treat certain aspects of mental illness. Have you and your colleagues seen a rise in patients making demands on trying some of those things that they've seen advertised? And if so, how do you deal with that client who may think that he or she has been convinced by the commercial that it's right for them, but you know that it possibly or probably might not be right for them? How are you dealing with that? Because it seems to be on the increase as we move forward in time.
Yeah, I certainly think so. And again, that's something that's just so bizarrely American. If you talk to people from other countries, and they're just amazed that we have ads for pharmaceuticals here. And I think that didn't start here until I talk about it in the book. So, but in like the 90s, I think, I think it can be really difficult, right? And I think they're just, even aside from like the issues like that, they're just such bizarre ads because you're trying to sell someone on something that they really don't understand. And then you always have that really like sort of auctioneer type voice reading the levels or side effects at the end, It certainly, those can be seductive for people who, have struggled for a while, and haven't found the right medication. They can see an ad and be like, oh, maybe that will be the one for me. And the truth is that, the placebo effect doesn't count for nothing. If you go into something thinking this is the best and newest medication I could take for my condition, sometimes it does work, because our minds are pretty powerful in that regard. But, I think that the truth is we still don't really understand how a lot of psychotropic medications work. If you, we all, and again, this is also in the introduction, but we talk about how, depression is a chemical imbalance, well, that's not true, or we don't know that's true. That was a theory. Nobody sort of professionally really believes that anymore, but it persists, and advertising doesn't necessarily claim that anymore because, it's long debunked, but it will kind of like play with that, and I've looked at like the websites for some of the newer antidepressants, and they won't say that it cures depression or that it addresses a chemical imbalance, but it's not really clear what it does, period. And I think one other thing they often leave out too, particularly for people with not as good insurances, is new medications are really expensive. I had someone, the former patient, show me once when they came out with the pill that cured Hep C, I think. He had a 30-day supply of it, and at Walgreens they print that little "you saved" link with your insurance, and it said he had saved $30,000 with his insurance. That bottle of pills, each one cost $1,000 each. And most of these psych meds aren't that expensive, but they are really expensive, and insurance companies don't really want to pony up for them. So you often require a patient to fail, is often the word used, on like Prozac, Lexapro, other medications have been around for a while before they'll even prescribe that. And then if they are allowed to prescribe that, there's usually some hoops to jump through, unless you have like the best insurance. And even then, I imagine it's a little bit of a pain. But yeah, it certainly doesn't do anyone a lot of favors, I would think, the patient or the prescribers or the therapists.
We have one more question on a similar topic. In addition to racial biases in diagnosis, the forms of remedies are different according to the class level of the audience. What is the difference between someone obtaining drugs on, say, a dealer's corner, as opposed to someone obtaining drugs at a pharmacist's counter? And how does class or race affect views on these methods of obtaining those drugs?
I think that's a really important question and something to consider. A lot of times you're talking about the same drugs. One of the more used drugs these days are the class of medications known as benzodiazepines, which is like Xanax, Ativan, Klonopin. And they're used to treat anxiety. They're not really meant for long-term use. They work really well at sort of bringing you down from like a 9 or a 10 to something more manageable. But they you can get used to them. They have some pretty profound risks associated with long-term use. They can, cause some, cognitive fog and stuff like that, even in short-term use. But because they're abused, what you can often see, is that in, like, say, the community mental health clinic where I used to work, if someone comes in and thinks that they need a benzodiazepine, their response would almost always be absolutely not. They prescribe them very infrequently, and saying, like, asking for one or kind of advocating for yourself that you need an anxiety medication. And there are others, I won't go into that right now, but other things that can treat anxiety. Besides those, would almost entirely always, like, throw up a brick wall, but then you would occasionally get people in from, like, the suburbs, whose insurance changed or whatever, and their doctor was giving them, 95 milligram tablets of Xanax every month or something like that, and that's very irresponsible. And I think some of that's on the wane. But, it's often the case that, the sort of medications that are available to you differs quite a bit depending upon what insurance you carry, and sort of the stigmas associated with them. Like I talk about this in the book, but, a lot of the stimulant medications we use to treat ADHD are pretty similar to amphetamines. They are sort of in the same general class, but it's far different if you get something from Walgreens, versus, like, buying something on the street, in terms of the stigma associated with it, and that's not to say it's not helpful for people, it is. But I think that, the way that we talk about, drugs that are illegal drug use, a lot of that is rooted in bias too. You can be studying the history of substances. Like, most substances were used by a lot of people, like, famously cocaine and Coca-Cola, until they grew associated with a certain, like, undesirable class, whether that's, Black people, Latinx people, Asian people, and then they became perceived as other and then thereby banned.
Thank you. We have one more question before we close out tonight. Do you have any recommendations for other books or documentaries for people to seek out if they want to learn more about diagnostic bias and mental health?
I do, yeah. I have listed a few titles here. So one that I used that was really helpful in some of the stuff that I just read is a book by Jonathan Metzl called The Protest Psychosis. And Metzl's kind of a historian of this sort of thing anyway. He has other good books on kind of this in the same journal field. But in The Protest Psychosis, he takes a look at prescribing patterns of this one community mental health center in Michigan, over several decades, and charts what I talked about, like the switch from kind of dreamy women as being people with schizophrenia to, sort of these dangerous African-American radicals or whatever, and sort of the ways in which treatment changed, became far more carceral, and, how eventually that center closed as a lot of the, because it was state-run, and a lot of the state-run facilities did, and most of the people who were there would now be incarcerated. So that's a fantastic book I would recommend. Andrew Scull has a book called Madness and Civilization. It's just kind of a general overview of the idea of mental illness, or madness as he calls it. As I mentioned, that's just something I find fascinating anyway, but it just kind of covers different ways that people have thought about mental suffering over the centuries. It's a great overview, and it's just a really fascinating read, I think. There's another book that sounds drier, but was actually really important for me in the writing of this book. And it's by a philosopher also at the University of Chicago named Arnold Davidson. And it's called The Emergence of Sexuality, Historical Epistemology and the Formation of Concepts. Actually, I had a good friend of mine recommend that book to me after I signed the contract to start writing this book. He's like, "Oh, you're reading Davidson, right?" I was like, "Oh, you didn't know." But that book is as sort of unwieldy as the title might be. Basically, talks about how diagnoses such as hysteria. One thing he writes frequently about is homosexuality. How those are products of certain psychiatric styles, what he calls psychiatric styles of reasoning. That something only exists as a disorder if you have certain words to in ways of thinking that make sense of it. So for a time it was people just couldn't, and people write far better on this than I do. So don't take this as like you should read the book. But people didn't have a concept that there would just be men who wanted to have sex with other men as like an orientation, or that was like who they were. It was thought that had to be either like a sign of criminality at first, or some sort of like organic issue going on. They thought like maybe there was like a male uterus some people had that caused them to do that. Until finally, it arrived first at like the psychiatric idea that it was this sort of mental illness for this reason, and then it wasn't at all. Of course, that's also something I chart in the book. But like I said, it's kind of, if any of that sounds Foucaultian to you, he is a sort of a Foucault scholar, and I think a lot of that shows up. But he takes it in really interesting directions. It's a meaty read, but definitely recommended.
Great. Well, that's really about all we have time for this evening, Jonathan. Are there any final words you'd like to offer our listeners before I close out?
I'm thankful for everyone who showed up and everyone who's watching this later. It feels weird to say that, I enjoy writing a book on such weighty things, but I wrote this sort of throughout the pandemic, and it was really important to me, and I'm really excited to get to share it with other people.
Well, it's been my pleasure to host you tonight. So for everyone out there watching, the book is Misdiagnosed by Jonathan Foyles. And to get a copy, you can pre-order from Belt Publishing or check it out at the Chicago Public Library after its September release. We do have it on order. We also encourage you to visit any of Chicago's independent bookstores to purchase a copy too. Tonight's program will be available on the Chicago Public Library YouTube page. If you have friends who weren't able to join us tonight, please invite them to watch it on demand, and also visit the Chicago Public Library website for many more upcoming virtual events at chicagopubliclibrary.org. Thank you again, Jonathan Foyles. Thanks to everyone tuning in, and to our technical and marketing teams. Thanks to all of you out there. Have a great night, and everyone please stay well.